Hello class, I'm going to provide your online lecture for week 2, day 2, and we're going to continue with our concept of elimination and talk about our two exemplars of constipation and diarrhea. I have up here on the screen the PowerPoint, which you already have uploaded in your Canvas course as well. Alright, when we talk about constipation, it can be defined as less than 3 bowel movements a week or difficulty passing stools. And those stools may be consistent of very dry, very hard stools, or actually no stools at all. It occurs when the movement of feces through the large intestines is very slow, allowing for more reabsorption of fluid. So let's look at the reasons why constipation may occur. The primary problem or the manifestation of another disease may be the reason that the patient is constipated. It could be an acute situation, which is often caused by organic process, or it could be chronic, where there is a change in bowel habits that persist or become more severe, or it could be caused by a tumor or some other obstruction that's not allowing that stool to pass freely. It can also be functional causes that impair storage, transport, or evacuation mechanisms. Oh, I don't know what psychogenic means. I'd be so mad if I put it in here. Shoot. Some of the other reasons why constipation may occur is because of some psychogenic factors, which means that the reason someone is experiencing this is not because of a physical reason, but because of a psychological reason. Another reason could be postponing defecation when the urge is felt, perception of satisfaction with defecation, and the overuse of laxatives and enemas. These are the risk factors of why people become constipated. Again, age is a big factor. Anyone over 65 years of age. Insufficient fiber or fluid intake, insufficient activity or immobility, irregular defecation habits, a change in a daily routine, lack of privacy, and the chronic use of laxatives or enemas. And other risk factors include IBS, which is irritable bowel syndrome, pelvic floor dysfunction or muscle damage, poor motility or slow transit, some neurological conditions, some emotional disturbances, and even medication. And we've talked about that as well. Some medications really have a tendency to make someone constipated. And these are some of the ways to prevent constipation. Some dietary methods: high fiber diet, drinking plenty of fluids, fiber supplements, and then of course some of the changes in lifestyle or behavioral methods: exercising regularly, not ignoring the urge to defecate, and even using stool softeners, laxatives, and only stimulant laxatives should be used only for a short time. The clinical manifestations which could alert someone that they are constipated is less frequent bowel movements than normal, not really kind of adhering to your normal pattern, frequent flatus, abdominal discomfort, diminished appetite, straining, passage of hard dry stools, a distended abdomen, and of course reduced bowel sounds. Adults must experience 2 or more of these symptoms for chronic constipation. Straining with defecation more than 25% of the time, lumpy or hard stools more than 25% of the time, a sensation of incomplete emptying more than 25% of the time, and use of manual maneuvers to facilitate emptying in more than 25% of defecations, and less than 3 bowel movements a week. Looking at the lifespan considerations when we talk about children, it's common for kids to get constipated, but it can be difficult to identify. It's very rare during infancy unless there's a mismanagement of diet. Bottle-fed infants are more prone to hard stools, where your breastfed babies really have no problems with constipation. Most frequent in toddlers and preschoolers. They may try to withhold their stool. School age through adolescence, limited at toileting time, and unfamiliar bathrooms as well. And with the older adult, it affects about 24 to 50% of older adults. Many older adults use laxatives daily. Fecal transit in the large intestine slows with aging. Loss of teeth makes chewing and swallowing difficult. Many of these older adults have some type of periodontal disease. Cultural influences and advertising encourages the overuse of laxatives, suppositories, and enemas. And we do see the media out there really telling people that this is the way to go when trying to have regular bowel movements. And we look at the pregnant woman, where mechanical pressure from the growing uterus contributes to the displacement of the small intestines. reducing motility, decreased gastric tone, increases smooth muscle relaxation, prolonging emptying time of the stomach and the bowel. And of course, we see hemorrhoids develop late in pregnancy as well. Some of the non-pharmacological therapies that we use is to educate the person by some of the prevention methods that I've just talked about. Of course, nutrition plays a big role in prevention of constipation, and when it does occur, how to manage it. Behavioral management, bowel training, biofeedback, and sometimes when it's very serious, we might see manual removal of stool. And now let's just talk about the opposite of constipation, diarrhea. It's the passage of liquid feces with increased frequency, results from a rapid movement of fecal content through the large intestine, the urge to defecate, difficult or impossible to control. Prior to the diarrhea, a person may experience cramps, increased bowel sounds. With excessive diarrhea, we may see a fluid and electrolyte loss, which could be very serious as well. Risk for skin breakdown. Diarrhea is more common in children. So let's recap a little bit of what this PowerPoint has talked about in regards to constipation. First of all, remember, one's bowel function can be affected by certain things that occur within the body, such as inflammation, infections, tumor, obstructions, or even changes in the structure of the bowel. We know what defines constipation. Again, it's fewer than 3 bowel movements per week, or the difficulty of passage of stools. And this term implies either the passage of a dry, hard stool or absolutely no passage of stool at all. And it also occurs when that movement of stool really does start to slow down. And when that happens, what is occurring is there's an additional absorption of fluid from the large intestines. So that's why it's really important that people continue to drink adequate fluids, which will help prevent constipation. Constipation in itself is not always a serious situation, but sometimes constipation may be a primary problem, or it could really be a symptom or a manifestation of something more serious that's occurring with someone, okay? And as I said before, acute constipation, which is somewhat of a different change in the person's normal bowel pattern, is frequently caused by an organic process. And that might be something due to some changes in the anatomy of the bowel, a neuromuscular problem, such as like multiple sclerosis, metabolic problem, or even some endocrine changes as well. But then we have people that really experience a problem with constipation that persists or becomes more frequent, or really becomes quite severe, which could, be the reason, because the person has a tumor or some kind of obstruction that is not allowing that stool to pass through. And remember too that constipation may also predispose children and older adults and pregnant women to the development of UTIs, which is really important, and sometimes we see that combination of problems exist. Pressure placed on the bladder, the uterus, the ureters, or the urethra by the colon when it contains a large amount of hard stools may cause structures of the urinary tract to develop a partial obstruction, and that makes perfect sense. So when urine is allowed to pool in one area for an extended amount of time, bacteria tends to grow, and this is where the person develops a urinary tract infection. Your book has a nice table on page 325. It's table 5-7, and it talks about the related causes of constipation. First, starting off with behavioral factors, and of course activity is a huge reason why people get constipated, where there is inactivity or lack of exercise. And of course dietary is another huge factor as well, especially when a person is intaking foods that really do not have a lot of fiber in them, or they're not taking enough fluids in, or even foods that are very highly processed, or one that abuses alcohol, and even some of the mineral deficiencies and even malnutrition may cause dietary problems that lead to constipation. And of course toileting, voluntary stool retention, perceived need to defecate on a schedule, and attempt to avoid discomfort related to defecation. And some of the physiological reasons are some structural reasons, obstructions, changes in the sphincters, and then of course the neurogenic, trauma affecting the spinal cord, and as I said before, multiple sclerosis, or even some kind of cerebral vascular accident such as a stroke or a CVA. Metabolic, we see patients with thyroid problems, particularly hypothyroid, uremia, and porphyria. And then, of course, medications, a lot of your antacids. We know about narcotics and opiates, some of your antidepressants, and there's a list in your book of the various medications that may cause constipation. And, of course, the psychological reasons, the somatic, where you have somatic pain or illnesses arising from the physical or emotional or even sexual abuse or trauma may cause a person to become constipated, anxiety, and of course depression. We talked about the risk factors, and of course many factors may influence a person's particularly bowel pattern, and some of those are just their lifestyle practices, such as exercise, or even just having irregular defecation habits. And lack of privacy is a big deal as well, especially for children. And the older generation who tends to depend on laxatives or even enemas, and then some of your GI problems such as irritable bowel syndrome, or some of the pelvic floor dysfunctions that may occur. And we know about some of the neurological conditions, and I mentioned multiple sclerosis, even Parkinson's disease, people who have had strokes in the past, or some of the emotional or cognitive problems that people may have as well. And then, of course, all the medications too. Prevention is really important, and the big factors that influence bowel habits are dietary intake, especially foods that are high in fiber, and of course getting in plenty of fluids, particularly water. Sometimes if your foods do not contain a high source of fiber, there are some fiber supplements out there that may also be taken to prevent constipation, but it's recommended that those are taken with plenty of water. Definitely exercising on a regular basis, and not ignoring the urge when you do have to defecate. So those are some of the big ones, all right? And overuse of those stimulant laxatives can also cause the bowel to become very dependent on the medications to get that activity and peristalsis going. We talked about constipation and what is the definition and what are those clinical manifestations. Usually it's someone who now has less than a usual pattern, and as said, unstated on the PowerPoint, frequent flatus, a lot of pain in their abdomen, straining, and when they do go, the stool is extremely hard. Okay. And one thing I wanted to talk about that the PowerPoint doesn't talk about is a fecal impaction. And this is a mass or a collection of hardened feces in the folds of the rectum or colon. And why this occurs is because there has been a prolonged time when that stool has been retained, in the bowel, and there is a large accumulation of fecal material. And sometimes these severe impactions may have the stool extending well into the sigmoid colon and beyond. And how you recognize that someone may have a fecal impaction is that if they start to pass some stool, and most of it is a diarrhea type of stool, that it's a liquid and it's very, very foul smelling. And this occurs as the liquid portion of the feces seeps out around the impacted mass. And another way to assess a person to see if they do have a fecal impaction is to manually do a digital rectal exam and kind of feel up in the rectum to see if there is stool present. And many times you can actually feel that very hardened stool, which indicates that there is a fecal impaction. And the only way to get that out of there is to actually remove it manually. Okay? And many times, along with the very, very nasty odor that may occur with that liquid stool leaking, many of these patients also suffer from rectal pain and also have a frequent non-productive desire to defecate. Usually when it's this severe, these patients do not feel good. They feel very sick to their stomach. They don't feel well. As said earlier, even with just simple constipation, you may feel somewhat nauseous or have a lack of appetite, but these people really feel bad when they haven't gone in quite a while, and they do have a fecal impaction. Plus, the abdomen will become very distended, and there's a possibility that these patients will not only be nauseous, but may also vomit as well. And many of them may experience abdominal cramping and a sensation of fullness in the rectal area. And how does it get this bad? Many times the reasons people have or develop a fecal impaction are poor defecation habits, and maybe they've been depending quite a long time on laxatives or enemas, and many times after some radiologic x-rays, such as the use of barium for upper and lower GI tract structures may actually be the cause. So when you ever know of a patient who's having these types of x-rays and they have to drink that barium, it's very important to make sure that you assess when they're able to move their bowels again. Many times we will give the patient a laxative or even an enema to make sure that he does pass that barium out, because otherwise it can stay up in the rectum and the colon, and it can get just as hard as a rock. Be careful when you do a digital exam. You've got to be very careful. It should be performed very gently and very carefully, and someone that does have some experience in that. And it is within our scope of practice as nurses, but sometimes check with the policies of the hospital to make sure that you don't need a physician's order for that manual manipulation and removal of the fecal impaction. The goal here is to prevent this fecal impaction from happening, and so it's really important that we assess, along with urinary elimination, that we assess bowel elimination as well. When we suspect that there is a fecal impaction, a lot of times the healthcare provider may order a type of enema, a retention enema, a cleansing enema, maybe two or 4 hours later after that one, and then maybe an additional enema or a suppository to make sure that the impaction in the stool is completely cleared away. All right. Someone that develops even simple or chronic constipation, the important thing here is to just educate the person about what is your normal pattern of defecation. Sometimes when chronic constipation occurs, it's necessary to find out why. Okay, especially if the person really is exercising, or maybe they are eating foods that are sufficient in fiber. Maybe it's time to do some diagnostic testing and some interventions with pharmacological treatment as well. The initial diagnostic exam for constipation is a DRE, which is a digital rectal exam. If they don't see anything, really serious with that type of an exam, and the constipation still continues, they may start doing some diagnostic examination. And that's where they might do like a barium enema, just to be sure there's no structural problems, or the patient doesn't have some type of tumor, or even some kind of diverticula. If the problem is acute, a possible sigmoidoscopy or colonoscopy may use for evaluation, and then what they'll also do is obtain tissue samples for the biopsy, just to make sure there's no beginning of any malignancies or tumors. Rectal muscle contraction and completeness of bowel elimination may also be tested by defecography and an anorectal manometry, and a colorectal transit study can determine how efficiently foods pass through the patient's GI tract. I'm not going to get into pharmacological therapy. You're going to learn about all the medications that you would give with patients who are constipated, and there is a table with medications on page 327 in your book, but I'm not going to go over those. You'll learn those in Pharmacology and Nursing 123. As I said, some of the non-pharmacological therapies are education, nutrition, behavioral management and bowel training, and biofeedback, where we can teach a patient about visual or auditory feedback about a specific body function. What we can do is teach the patient how to strengthen those rectal sphincters and other rectal muscles. So that's what they may do with those patients as well. Or if they're prone to fecal impactions, patients with fecal impactions may need to have hard masses of stool broken up manually. Okay. And as I said before, this should be somebody that's experienced, because anytime you're, working around the anal area, you could stimulate that vagus nerve and cause the patient to, develop, a slow heart rate, and cause some cardiac issues to occur. Many times, suppositories or enemas are used to clear out the stool, and maybe they'll continue to give suppositories over a period of a few days just to make sure that the impaction is completely gone. And they want to do this very delicately and very slowly to prevent any injury to the bowel or to the anus. So things to think about. Okay. Again, we look at the lifespan consideration, looking at constipation in children and adults. Constipation is a common complaint in the pediatric population, and it does account for up to 20 to 25% of GI complaints. And we know that with children, there are varying bowel patterns that occur with kids, and it's really difficult to kind of assess what's normal for one kid, maybe not normal for another. With infants, we know that they usually go quite frequently during the day, especially breastfed babies. Constipation is not as common in infants as it used to be back years ago. They've made the formula much closer to the content of breast milk. It only is reported in about 9% of infants that are given primarily and exclusively baby formula. Again, inactivity is a major risk factor for constipation for any one at any age. Like I said, constipation is during infancy is really uncommon and is usually managed through a child's or an infant's diet. Constipation occurs most frequently, and please remember this, in toddlers and preschoolers, and is often associated with learning to control bodily functions. Many toddlers really don't like to use the bathroom and have bowel movements, and that's why a lot of them kind of relate having a bowel movement as an uncomfortable experience, and that's why you'll see a lot of toddlers begin to withhold stools or hiding from parents until that urge to defecate has passed, because they really don't want to take part in that experience because it can be painful. And so this is why a lot of times these toddlers end up really retaining that stool, and this can definitely lead to hard stools and painful defecation. And this could really cause a lot of trauma for these kids. Can actually cause structural damage as a result of a tear in the mucosal tissues of the rectum or anus. Constipation may also occur as a result of limited time for toileting, because we know children, especially in school, are very busy and they delay the need to run to the bathroom because they're involved with play or other activities, and they're playing sports, and so they don't have a lot of time to spend in the bathroom. And a lot of kids do not like to have bowel movements in a bathroom that they're not familiar with as well. And constipation in toddlers, school-age children, and even adolescents may result in overflow fecal incontinence. And a lot of times parents think, oh boy, my child has diarrhea, and may think the overflow is diarrhea and seek medical care to find out that the incontinence is liquid stool leaking around, unfortunately, a fecal impaction. So it's necessary to have that stool evaluated as well. So that's why early on it's necessary to have encouragement from parents and relaxation of bathroom privileges. At school, do keep the person or the child on a regular defecation pattern, okay? Usually, many times, the child will feel the urge to defecate about an hour after they eat, and it's kind of good for parents to kind of watch for that and encourage the child to go into the bathroom, okay? Again, their diet is important as well, encouraging to eat foods that are high in fiber as well as grains, fruits, and vegetables. That will really help a lot with their constipation problem. And it talks about the types of laxatives that may be safe for children, but like I said, I'm not going to go into that since we're not talking about the pharmacological treatment as well. We know constipation in pregnant women is very common, and constipation in the older adult. So make sure you go over those as well. Just want to talk a little bit about fecal incontinence or bowel incontinence. There is a time when we might see that with our patients, and that is the loss of voluntary control of fecal and gaseous discharges through the anal sphincter. This is not as frequent as urinary incontinence, but is no less distressing to a person, obviously. Why does this happen? Usually it's caused by impaired functioning of the anal sphincter or its nerve supply, such as some of the neuromuscular diseases, spinal cord traumas, and even tumors of the external and anal sphincter muscle. Usually when this occurs, it's kind of telling the person that there's a problem. It's kind of a manifestation of a disorder rather than that being the only problem itself. Your book talks about two types of bowel incontinence, and those are partial and major. And partial incontinence is the inability to control flaters or to prevent minor soiling. And major incontinence is the inability to control feces of normal consistency. So there are two types of different disorders, okay? And it can come from multiple factors. Sometimes it's because of sensory or either motor control of the rectum and the anal sphincters. And if the external sphincter is paralyzed as a result of, say, a spinal cord injury, then defecation occurs automatically when the internal sphincter relaxes with the defecation reflex. Diarrhea, stool impaction, tumors, pelvic floor relaxation, or loss of sphincter tone can all cause fecal incontinence. And other causes could be neurologically, as I said, from spinal cord injuries, local trauma, maybe obstetrical tears during a delivery, inflammatory process such as an infection or even radiation treatment, or the psychological problems such as depression, confusion, or delirium. So that pretty much sums up your reading in regards to constipation. And one thing I just wanted to talk about was we see quite a dependency on laxatives with the older patient. And as your book talks about, it says constipation affects between 24 and 50% of older adults. And in this population, about 10 to 18% of individuals in the community setting use laxatives daily. And in the extended care setting, as many as 74% receive daily laxatives. So that's quite a huge number. But there may be a time that after we do an assessment on our patients, when laxatives would never be given. And that would be if we would suspect appendicitis or any enteritis, which is an inflammation of the intestines, especially the small, that may cause diarrhea, ulcerative colitis, diverticulitis, any intestinal obstruction, a fecal impaction, or even an undiagnosed abdominal pain, all right? Because we wouldn't want to cause any severe injury or a perforation to that area if we gave that laxative. So just wanted to just make sure that you understood that, and I'm sure you're learning about that in Nursing 123. Class, what I have up here on the screen is a website for digestive diseases. And this has been developed by the National Institute of Diabetes and Digestive and Kidney Diseases, and kind of goes over the same information that we talked about earlier in regards to constipation and diarrhea. And I'd like you to go on this website and look at some of this health information. Here's a definition and facts for constipation. What is constipation? How common is it? Who is more likely to become constipated? And pretty much defines it the way your book defines it. Again, being concerned when someone has constipation. It's not a disease, but it may be a symptom of another medical problem. Constipation may last for a short time or a long time, all right? And there's also, about, how common is it, who is more likely to become constipated. And the same goes for information about diarrhea as well, okay? If you search down here, you'll see that it'll talk about diarrhea, symptoms and causes of diarrhea right here. And this is great information for the public. People with diarrhea caused by some infections may also have one or more of the following symptoms: bloody stools, fever and chills, lightheadedness and dizziness, and vomiting. So, very important to be able to assess that diarrhea as well when any of these additional problems are associated with the diarrhea. Okay, so I just wanted to bring this to your attention. So please go on this website, and this is also uploaded in your Canvas course as well. All right, very good. I won't read this. I'll give you an opportunity to be able to review this information as well. Okay, class, what I have up here is an activity just to kind of review some of the information that we've gone over, either from the PowerPoint or information that I kind of reviewed with you that came out of your book, okay? Here's a situation where we have Mrs. James is an active 91-year-old who has lived alone since her husband's death 9 years ago. She likes to dance at the senior center with her friends and plays bridge with the ladies twice a week. When she visits her provider's office, she reports that she's begun taking laxatives once or twice a week over the past 2 months because she has been experiencing constipation. The nurse questions for normal eating habits and learns that she wakes in the morning and eats an egg with white toast and drinks a cup of tea, and she has every day of her life for as long as she can remember. She usually eats lunch out, normally a salad, soup, or a sandwich. For dinner, she normally eats a small serving of meat, frozen vegetables, and a starch, either a potato or rice. She denies any change in her diet or exercise level. She reports feeling the need to move her bowels but can't defecate without the use of laxatives. After taking a laxative, she reports good results. She denies any blood in the stool, abdominal pain, or diarrhea. The provider performs testing and determines there is no physiological cause for her symptoms. Develop a teaching plan for this patient to help reduce that constipation. Now remember, she's 91 years old. That's really important to know. But she seems pretty healthy. So let's think about this. We know her age is a risk factor, so she's prone to constipation, and this is unfortunately what she has developed. So let's take a look at her diet. So think about her diet. We've got specific foods that she's eating with all 3 of her meals. So let's look at her breakfast. She has an egg and white toast. Maybe we might want to change that white toast to whole wheat toast, or maybe a suggestion of a whole grain cereal such as oatmeal, or even including some fruit in her breakfast as well. We might want to add an orange or an apple to lunch, and maybe we might encourage her to eat a baked potato, since she does like potatoes, which would include the skin, which is great fiber. We don't really know much about her fluid intake, but as long as she has no other problems, especially with heart failure or limited amount of fluid she's able to take in, we really should encourage her to drink at least 2,000 mLs of fluid a day, and we could include that with water and maybe mix it up with some juices. maybe some prune juice or apple juice if she likes those. She gets some exercise because it says she is going to the senior center twice a week, but maybe we would encourage her to get out and maybe walk a little bit. And that doesn't have to be, a 20-mile walk. We might encourage her to start out slow, as long as she's steady, and maybe walk for at least 5 or 10 minutes, and then increase that a little bit each day. Try to get on some kind of a regular pattern and have a bowel movement at the same time every day. And the minute that she feels the urge to defecate, to go to the bathroom and to, hopefully have a good bowel movement with that. And really to try to not depend on those laxatives, because she sounds like she's getting very dependent on that. But the good thing is she has no physiological reason for her constipation, so that's a good thing. So those are some of the things that we may include in her teaching plan. And maybe some of you have, a few other ideas as well. Okay? All right. So let's look at Appendix 11 here. Kind of thinking about and reviewing some of the information that we have learned about today regarding constipation. So let's look at question 1. What impact does the concept of mobility have on elimination? I want you to think about it. Maybe as you're listening to this lecture, you might want to turn it off and see if you can answer these questions. The more mobile one is, the better the elimination patterns. Lack of exercise, bed rest, or inactivity can all contribute to constipation. We know this is huge. It's about lifestyle. So patients that maybe are immobile or have limited mobility, we might really want to pay very close attention to their elimination patterns, especially with their bowel movements. All right, question 2. How can the nurse promote normal bowel elimination in the client with altered mobility? Just what I was talking about. We might want to make sure that the person is getting plenty of fluids. Let's look at their diet, making sure that they can help determine and choose those foods that might have a little bit of higher fiber. Maybe we could possibly add a stool softener to their regimen of medications, and once in a while a laxative. Hopefully with a combination of the two, we can hopefully get the person on a good pattern and a good elimination program, that we don't see any complications like fecal impactions occurring. And then of course to assess the consistency of the stool, making sure that it's of good consistency and not too much watery, and hopefully it's of soft consistency so the patient is able to eliminate without any problems. As many times when patients are constipated, many times they might develop hemorrhoids, which can be very painful, and they can even bleed as well. It's when those veins get very inflamed and engorged as well. So that's what that hemorrhoids are all about. All right, question 3. When caring for a patient with liver disease, what special precautions must the nurse eliminate related to bowel elimination? And this is something you may not have had yet. Maybe remember a little bit with your anatomy and physiology when you talk about the liver. But the liver disease will often affect water and salt regulation, and there be signs of fluid overload. Fluids may have to be restricted with liver disease, thus contributing to possible constipation. So this client requires regular bowel elimination to eliminate protein and ammonia. Measures will need to be provided to ensure regular bowel elimination, whether these be oral or by an enema. All right, so he's kind of a special type of person, a special type of patient that we have to look at his condition in a very different way because of his liver disease, and that may be caused by cirrhosis or hepatic cancer or whatever the problem is. Okay, question 4. When caring for a client diagnosed with hypothyroidism, what nursing implementations can be initiated to reduce the impact of this disorder on bowel elimination? Patients with hypothyroid are at risk for constipation related to decreased peristalsis, decreased appetite, diminished food intake, and decreased activity. The client needs to be encouraged to drink at least 2,000 mL of fluids a day, and a high-fiber diet should be part of the plan along with some physical activity. You haven't had this yet. We're going to talk about the thyroid probably in week 6 or 7 when we talk about metabolism. So you may not know that constipation may be a sign of hypothyroidism, a metabolic issue that arises. So you maybe would not know that. All right, so that's Appendix 11 and just answering some questions regarding constipation. All right. So right here I've got some of these practice questions from Pearson that relate to your assigned reading. Question 1, which of the following statements provides evidence that an older adult who is prone to constipation is in need of further teaching? First, I need to drink 1.5 to 2 quarts of liquid each day. 2, I need to take a laxative such as milk of magnesia if I don't have a bowel movement every day. 3, if my bowel pattern changes on its own, I should call you. 4, eating my meals at regular times is likely to result in regular bowel movements. Which one do you think it is? And the answer is I need to take a laxative such as milk of magnesia if I don't have a bowel movement every day. Let's look at that rationale because I know that's the answer that you all chose. The standard of practice in assisting older adults to maintain normal function of the GI tract is promotion of regular ingestion of a well-balanced diet, adequate fluid intake, and regular exercise. If these activities are all present and the bowel pattern is still not regular, this abnormality should be reported to the client's primary care provider. And some people don't go every day, so that may not be their normal pattern. And sometimes the older adult thinks that they need to go every day, and that's why they're consistently and continuously taking laxatives. Okay, question 2. The mother of a breastfed infant calls the physician's office to report her infant is constipated. The nurse questions the mother and learns the infant last stooled 4 days ago, and the stool was yellow and pasty and passed without straining. The infant has no other symptoms and has been eating, sleeping, and acting normally. So we're going to continue. With this question. The mother denies any change in the appearance of the infant's abdomen and says the infant does not cry when the abdomen is palpated. The nurse would tell the mother which of the following. Bring the infant to the office to be seen today. Number 1. Number 2, give the infant 2 tablespoons of Karo syrup and 4 ounces of water. Number 3, the infant's stooling pattern is normal. And number 4, feed the infant 2 ounces of prepared glucose water. So think about that. All right, so what would be the answer? And I know you're all going to get it right. And the answer is number 3. The infant's stooling pattern is normal. So let's look at the rationale for that. It is not unusual for infants to stool 2 to 3 times per week. While some infants may stool with each breastfeeding, others may stool less frequently and still be within normal limits. A better indicator of constipation is the passage of hard stools. Since this infant's last stool was a normal pasty yellow, the mother should be reassured that the infant's stooling pattern is normal. So you have to look at everything when you're looking at the stool itself, and is this a serious situation that needs attention by the physician. All right. And if the infant does not stool over the next few days, or if the infant has abdominal distension, the child is crying that does not stop with comforting or straining to stool, the mother should call back so the infant can be seen by the provider. Karo syrup should not be given to infants under 1 year because it is linked to infant botulism. Glucose may be prescribed for a constipated infant, but this infant is not constipated. There is no need for the infant to be seen by the provider today. Question 3. The nurse is working with the family of an older client with bowel incontinence. Which of the following interventions will the nurse teach the family about bowel incontinence? Place the client in a diaper at all times, number 1. Number 2, place the client on the commode at the same time every day. Number 3, do not try to stimulate stools with suppositories. And number 4, ask the client to tell the family when the urge to defecate is felt. Think about this now. It kind of goes back to when we talked about urinary incontinence, and we looked at that one case study where the lady was living in a extended living facility. So think of that when you're choosing the answer. And the answer is 2. Place the client on the commode at the same time every day. And we know what the rationale with that would be. It teaches the family how to retrain the bowel. This is done by placing the client on the commode at the same time every day and possibly using suppositories to stimulate the bowel. Once that retraining is reestablished, the suppositories are stopped. Diapers are demeaning and should be used only if retraining fails. Ask the client to tell the family when the need to defecate is felt is not retraining the bowel. All right, number 4. The nurse teaches clients that repeatedly ignore the sensation of needing to defecate could result in 1, constipation, 2, diarrhea, 3, incontinence, or 4, hemorrhoids. And the answer to that is constipation. And some of you may have chosen hemorrhoids, and that also could be an answer. So habitually ignoring the urge to defecate can lead to constipation through loss of the natural urge and the accumulation of feces. Diarrhea will not result. If anything, there is increased opportunity for water reabsorption because the stool remains in the colon, leading to firmer stools. And ignoring the urge shows a strong voluntary sphincter, not a weak one that could result in incontinence. Hemorrhoids would occur only if severe drying of the stool occurs and thus repeated need to strain to pass stool. And even and also looking at the stools and if they were extremely hard. So this is another way to kind of go over the information that we learned about. And now I'm going to bring up on the next lecture the elimination game, okay, after we work on another case study. All right, thank you, and great job on these questions. You're doing very, very well with these. You guys are reading and retaining the information, and I'm so proud of you, so keep up the great work.